Good day, and welcome to the ASTHO Desk Briefing on COVID-19 testing. Today's conference is being recorded. During the presentation, all lines will be in a listen-only mode. We will take Q&A following the presenter's remarks. At this time, I would like to turn the conference over to Mr. Mike Fraser, Chief Executive Officer of ASTHO. Please go ahead.
Thanks a lot, Olivia, and good afternoon to those of us who are on the Eastern Seaboard, and good morning to those of you who are in earlier time zones. We thank you all for joining us. This call is on the record. It's for the media, and I'm really pleased to have the chance to provide this opportunity for media to connect with health officials and public health experts who are working tirelessly on several issues, of which testing is a very significant one. Due to the high number of folks expected on the call, we do have you all on mute, but we're going to give you plenty of time for questions. We've allotted an hour for this entire event, and I think we've got maybe 15 or 20 minutes of prepared remarks. So we want to make sure you get your questions and have plenty of time for that conversation. The goal of today's call is really to discuss the issue of COVID testing and some of the differences between COVID tests. I think many of you obviously saw the experience with the governor of Ohio, Governor DeWine's experience with getting a false positive test on a rapid test before his meeting with President Trump, and then getting two negative tests on a different kind of test that he took afterwards. And we're really concerned that these kinds of experiences will confuse the public at a time when we really want to encourage people to get tested for COVID and help mitigate and contain COVID across the country. We're also very aware of stories specific to testing delays, particularly in private laboratory results being connected back to patients. So we'll talk a little bit about that. And there are obviously some issues around testing, but also data reporting in terms of how those results get shared and the public health action that follows those data when they are shared. So we're going to discuss a little bit of that, as well as some supply chain issues when it comes to COVID testing. So lots of ground to cover, and we've got great cadre of experts here. I'm joined by Dr. Rachel Levine, who's the Secretary of Health at the Pennsylvania Department of Health. And she's the president of ASTHO for this year's term. I'm also joined by Dr. Eric Blank, who's the Chief Program Officer for the Association of Public Health Laboratories, which represents all the public health laboratorians in the 59 states and territories. And I'm also joined by Jennifer Nuzzo. Dr. Nuzzo is a senior scholar and associate professor at the Johns Hopkins Bloomberg School of Public Health Center for Health Security. It's really a pleasure to welcome all three of them. We're going to start with Jennifer, if you don't mind. She's going to describe some of the current testing types available to states and some of the differences in the tests and why there are false positives and false negatives associated with them. So Jennifer, I'm going to turn it over to you, and then when you're done, can you please turn it over to Dr. Levine.
Sure. Wonderful. Thanks so much, and thanks to everyone for chiming in on this call. And I'm going to just preface this by saying I am not a laboratorian. I'm an epidemiologist. So when I speak about testing, I'll probably be speaking about it in the context of what the public health impacts are going to be, rather than the deep details on the specific tests. But really, when we're talking about testing for COVID-19, I mean, the first kind of bifurcation in the conversation is whether we're talking about tests for the infection, the viral tests, or if we're talking about tests for evidence of potentially prior infection, the antibody tests. In the context of this conversation, I think it's probably best to focus on the viral tests, the tests we're using to identify people who may be infected with COVID-19. And there we see really two categories. So the molecular-based tests that are looking for evidence of the genetic material of the virus, and probably the other category that we'll be hearing increasingly about are the antigen tests, which are looking for perhaps surface proteins for the virus. For the most part, molecular tests have been the ones in probably greatest use, but we will increasingly hear about the antigen-based tests, particularly as states are pursuing these approaches. New technologies are coming online, and they come with their own set of considerations. Probably the thing to stress about these is, first of all, when we are talking about how well these tests perform, there are a few considerations that I think have not been well described for the public. One is, people, we generally hear, particularly with the molecular-based test, the PCR test that we're all most familiar with, that a positive is a positive, but a negative is probably a negative, but maybe not so much. And where the negative may not so much be a negative is possibly someone was tested too early, or possibly there was some kind of error, perhaps the specimen wasn't obtained properly, or there was an error in potentially performing the test. Now with the use of antigen-based tests, we largely have the same considerations that a positive is likely a positive and a negative may not be a negative. With antigen-based tests, you typically hear that they have a lower sensitivity, so they may have higher likelihood of false negatives rather. But as we saw in the example of Ohio governor, false positives are possible. And whether those false positives are due to the technology, probably unlikely, more likely that the test wasn't performed according to the specifications. We don't really know. But either way, when people hear about these sort of high-profile examples of errors, they, of course, raise concerns. And the Ohio governor was, out in front about this, saying, this is not a reason to not trust the test results, but this is something that can happen. Obviously, antigen-based tests are going to be increasingly used. They offer a number of advantages in the sense that they may just diversify the testing approaches and the materials that the tests use, and the more materials that we can rely upon, perhaps less strain on any particular one manufacturer or one particular supply chain. Also, antigen-based tests potentially can be performed outside of the laboratory and may return results in a faster time frame. So each of these sorts of approaches have their own kind of strengths and weaknesses, and in thinking about which tests to use and which tests to use where and in which population, I mean, it is really a whole series of considerations that states or providers have to go through. This is a really complicated issue, and I'm happy to say that colleagues of mine at the Center for Health Security have developed a really deep dive explainer of all these different types of tests, the breakdown between molecular tests and antigen tests, the kind of strengths and weaknesses, and then some other kind of up-and-coming testing approaches that we'll probably hear more about. They have a running list of those devices that have received EUA designation from the FDA, and all of that can be found on our website. And I'm happy to share that link with anybody who's interested later if you want to get into the specifics. So rather than do that, I will just say some of the things that I often am asked about testing that I just wanted to relay to practitioners because this is questions that journalists have and also members of the public. And I think we need to kind of keep these in mind as we're communicating about these tests. The first one is as we push to get more people tested, one of the phrases that I sometimes hear being said is, come find out your status, know your status. And as I mentioned, one of the ways that we can have a false negative test result is that somebody can be tested too early. And so I think it's really important as we are communicating to people when they are being tested that test that's being taken at that moment when they eventually get the test results back, that reflects their status at that moment in time and not necessarily the next day or the day thereafter. And so that's one of the challenges in being tested is that knowing exactly when to be tested is part of the equation of trying to optimize the use of these tests. So that's just an area where I think potentially we need some better communication. And that also, if people are symptomatic and they go to get tested, it's really important that they stay quarantined at home until they get their test results back. As we are hearing about longer test turnaround times, particularly at the commercial labs, as was said. That, of course, becomes a harder prospect. But the value of that test will be reduced if people, kind of go about their lives and while they're waiting for that test results back. It's hard to tell people to stay home if they're not sick, but absolutely if they're sick, they should stay home until they get those test results back. And then just the third area where I think we need to give some deep consideration is our approach to testing people without any symptoms and any epidemiologic criteria. One of the ways that tests can give us a hard-to-interpret answer is if we apply even a test that has a high sensitivity and specificity. When we apply it to a population that has a low prevalence, the positive predictive value, the ability to interpret a positive result, becomes harder. And so this is something that we are seeing increasingly as organizations are relying on tests as part of their safety strategies, their safety protocols, their return to work, et cetera, where they start screening people who have no symptoms and no particular reason to think that they may be infected other than we're just interested in knowing if they are so that we could potentially exclude them from participating in whatever the activity is. I have been involved in advising a number of organizations who have adopted testing strategies like this, and I can tell you they tend to be more fraught with problems than one would anticipate. A positive test result this is where we see the potential to have test results that are hard to interpret, and it causes operational challenges. And so this, I think, is one of the issues that we'll have to think about going further, think about as the weeks and months continue, when you see more organizations increasingly wanting to use these tests as part of their safety protocols, which is how do we interpret the results when we don't have the perhaps luxury of having clinical or epidemiologic criteria to increase our suspicion that the person is infected. So these aren't things that have been really worked out, but I think there are certainly things that will come up over and over again, and for which having, I think, a preemptive strategy will be helpful. It's all in there, and I'm happy to take questions later, but I will turn it over to Dr. Levine now.
Well, good afternoon. Thank you so much. I appreciate that. So I wanted us to give you a picture of testing in Pennsylvania. So, of course, we are working very, very closely with all of our stakeholders and partners in Pennsylvania to address the COVID-19 pandemic. And one of the key aspects of our strategy is testing. Of course, that's critical for containment, and it's also critical in terms of data for any mitigation efforts. We have worked to expand our testing significantly over the last 4 months. We are now testing over the last 30 days approximately 22,000 specimens per day. We are testing over 4% of the population every month now, and we've tested totally about 14% of the population in Pennsylvania. Primarily, we are relying upon the molecular testing, the PCR testing that was described, but we agree certainly that we're seeing more and more antigen tests with the issues about sensitivity and specificity that were discussed. There are a number of different ways that testing is done in Pennsylvania. There are about 445 different locations where Pennsylvanians can get tested. We are certainly prioritizing anybody with symptoms, and we don't yet have the capacity to do more population-based type of surveillance testing, although that would be really interesting in the future. So really this is diagnostic testing primarily right now with the PCR molecular tests. So we are doing priority testing at our laboratories. So these might be, for instance, nursing homes, et cetera. And we can do approximately 1,000 or more tests at our laboratory every day. And those tests come back in 24 to 48 hours. In addition, many of the hospitals and health systems are doing testing, and they have many different testing sites in their locations. They can usually get their tests back in 24 to 48 hours. And then, of course, there are other testing locations. That includes our federally qualified health centers, or FQHCs, which we're using for testing. That includes actually a number of different commercial locations, such as Walmart, Walgreens, Rite Aid, and CVS, which are doing a lot of testing. And they're sending their tests primarily to commercial laboratories, as are some of the other hospitals. The commercial laboratories have had some challenges in terms of getting the tests back. So some of the tests have been coming back in test results back in 7 days, 10 days. That makes it really difficult for us to do our containment activities, which include case investigations and contact tracing, in an efficient way if we get tests back in 12 to 14 days. We actually did speak with the president and CEO of LabCorp yesterday, and they are really making significant expansion of their testing and are getting tests back really in the last week or so, within about two or more days. And we just had an email actually from Quest that they are looking to expand their testing capacity and are trying to get their tests back in 2 to 3 days. That would be great. There are some other commercial laboratories that are still struggling, but we're very pleased with recent progress with LabCorp and Quest. In addition, there are issues in terms of the reagents and chemicals for the different testing platforms. And we have heard from a number of different academic centers that they're having challenges getting the reagents and chemicals for their platforms, particularly the Hologic Panther platform and the Roche platform. And they say they could be doing, twice as many tests if they had more reagents. So, we have reached out to those companies, and we have reached out to the federal government to try to see if we can source more of those chemicals. We have heard that because of the challenges in the South and the West in the United States, that sometimes they're being prioritized in terms of some of these reagents, and I guess I can understand that, but we need them in Pennsylvania to be able to continue to expand our testing and testing even further. One of the hallmarks of our testing has been the testing of the nursing homes. We have completed testing of every patient and every staff in our nursing homes, and now we're working on retesting protocols, which will need to continue ongoing, in an ongoing way, to be able to detect asymptomatic individuals in those facilities, which house really some of our most vulnerable citizens. In addition, health equity is very important, and it's critical to make sure that minority communities and vulnerable communities have access to testing, again, for our containment efforts and mitigation efforts. So I am also pleased to answer questions, but I am now pleased to introduce Dr. Eric Blank from APHL, who will talk about other testing obstacles.
Thank you, Dr. Levine. Dr. Nuzzo did a very good job of articulating the test and the different kinds of tests and some of the issues with testing that have been reported publicly and that we have all discussed with the media over the course of this response. I think I'll be brief. In order, the obstacles have already been described somewhat. There's going to be continued issues with supply chain. One of our members, for another purpose, said it takes 30 different things for them to do a COVID test. And that means that includes the actual test kit itself, extractions, the chemicals, the buffers, the plastics, things to get the samples back and forth, the swabs. He said if any one of those 30 components has a supply chain issue, I can't do that test. And so this is an extremely complicated issue, and the supply chain issues took us aback at the outset until we realized that this really is a global issue. It's not just simply a U.S. issue. And as been alluded to by both Dr. Levine and Dr. Nuzzo, there is competition for the testing resources across the board between, within the laboratory community broadly. And so we anticipate that this will be an issue ongoing in the response. And we're gratified to hear that Quest and LabCorp both are wanting to ramp up again, because back in March, they went through a ramp-up phase that got them to where they're increased amount of testing now. We're pleased to hear that they're going to do some more ramping up. I think that will ease the situation, but these are not going to happen immediately. To retool, to refit, to bring on another laboratory online is a multi-week process. So, help is on the way, but it will be a little bit before it gets here. I think the only other thing that I would mention is that APHL and our colleagues, the Council of State and Territorial Epidemiologists, are starting to think through, as we are on the edge of flu season, of how in particular does public health do smarter testing? We understand that we're going to be facing these shortages. How do we make best use of the resources that we have at public health's disposal to support the things that Dr. Levine was saying are important priorities for the Pennsylvania Public Health Agency? But that's where all of our members are. They're doing testing in support of what the state has set as a priority for them. And how do they do it smarter? And we look at the influenza surveillance model that has been used for many years, where you don't test everybody, even though that is one of the things that we need to do. But from a public health perspective, we don't need to test everybody. We need to know where the disease is. We need to do that surveillance. And where we need to do the diagnostic testing that has been described, from a public health standpoint, we do that too, but we need to start building in some of that surveillance of tracking where the disease is, where the hot spots, identify those vulnerable populations, focus efforts on them, and then work with the commercial sector and the healthcare providers to provide the necessary services on a more regular basis to them. So we're beginning to think through that process to help at least maintain a certain level of testing that's going to benefit the public health as well as meet the needs both of healthcare and, where appropriate, businesses, colleges, universities, and schools. And I'll stop there and turn it back over to Mike.
Thanks, Eric. That was great. I really appreciate that. And all of our speakers, Jennifer, Rachel, thank you. What I'd like to do, Olivia, now is open it up for questions, and we'll let folks queue up for that. And in the meantime, Eric, it might be nice if you don't mind just following up, and then Olivia will get some questions. What is this, and Rachel mentioned it as well, what is this difference between diagnostic testing and public health surveillance? Why is that significant?
It's diagnostic testing clearly is for the patient's benefit, for the individual's patient benefit, and the healthcare provider or whoever is overseeing that patient's health care wants that information to appropriately manage and treat that patient. So in the COVID case, to be able to tell that patient, you need to quarantine, you need to isolate, your family needs to take precautions, your family may need to be tested because they've been in contact with you, and so on. From a public health perspective, all of that is important, but we're looking at it from the community and population perspective. We want to know, where is this? I mean, we've got, just in the Virginia, Maryland, and D.C. area, you have very, very different rates of positivity. And from 7% in Virginia down to just under 4% in Maryland, to low 3% in D.C. Why is that? Where are the populations that do have a higher prevalence? Where are those communities of color, of minority communities that we know suffered more proportionately from COVID? So we need to take all that information that's being reported, public health takes all that information that's being reported and turns it into something that they can take some action on. And yes, they may need the diagnostic testing in specific situations, as Dr. Levine described, for the long-term care facilities and the nursing homes. but and certainly doing a diagnostic test that will be reported back to the healthcare provider that's involved from a public health laboratory, but it's also being reported back to the public health, and that information is put in with all the other testing that Dr. Levine described that's going on in her jurisdiction to try and identify, where are the hot spots, where do we need to target public health efforts, where do we need to work with our partners in healthcare and in the commercial and private laboratory sector to make sure that there's enough testing available to go into those places to try and tamp things down a bit and support the mitigation efforts.
Great, thanks, Eric. Rachel, anything to add to that?
No, I think we should just proceed with the questions. Thanks, Mike.
Sure, sounds good. Olivia, I'll turn it over to questions.
Of course. If you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press *1 to ask a question. With several questions in queue, we will go to our first caller. Please go ahead.
Yes, hi. This is Alicia Alt with Medscape Medical News. All of you have made reference to the Quest and LabCorp emails, and also Admiral Jawar put out a press release or a statement this morning talking about these 2 to 3 day turnaround times that are supposed to be coming online. In fact, he said, we estimate that nearly 90% of all tests are being completed within 3 days. I'm just wondering how that jives with, say, the experience in Pennsylvania, or whether this sounds reasonable. Thank you.
This is Dr. Rachel Levine. Thank you for that question. I think it is improving. So there had been a time when it was in March and April where it was extremely difficult to get any tests, of course, and then things significantly improved the latter half of May and June, and then in July the wait times became more difficult as there was, an explosion of tests being done in the United States, and especially in the southern part of the United States and in the western part of the United States, states such as Florida and Texas and Arizona, California, but then others. So the wait times increased to more than a week, and at times 10 to 14 days. I think that now with expansions for Quest and LabCorp, that is improving, and so we are seeing that the wait times are improving. There are other commercial laboratories that are still have longer wait times, but we are seeing improvement with Quest and LabCorp, and that's a great advance. So things are getting better.
Thank you.
Any other comment on the turnaround and the experience with the 3-day testing wait for results?
This is Jennifer. I'll just chime in and say that I really wish this would be something that we were tracking publicly, because, one of the things is we have to consider what the turnaround time is for hospitalized patients versus outpatient, and even within a given state, you go one place, it could take you more than a week, and you can go another place and you can get test results in 2 days. But from the public's perspective, there's no way to know where to go in order to get the faster tests. So I just really lament that we don't have better data other than these highly summarized statistics, that it's really hard to interpret on a state-by-state basis, and also even on a facility-by-facility basis, and what sorts of patients are the ones contributing to that. I've heard concerns that a lot of the national average statistics are heavily driven by hospitalized patients, but, again, this is not an area where there's publicly available data that we can vet.
I don't have anything.
Jennifer, why don't we take another question then?
Caller, please go ahead with your question.
Hi, this is Emma Court with Bloomberg News. I'm wondering if any of the folks on this call have any reason to believe supply chain issues will change or alleviate in the coming months? I've heard lab testing executive say he's heard that from supply chain companies. Is that something you guys have heard as well?
Well, this is Eric, and I think my observation and my sense is we're going to have supply chain issues throughout. Now, they're not going to be as dramatic or as bad as they were back in March. I think that the manufacturers did a fair job of ramping up, but as we heard from Dr. Levine, even the big manufacturers are having some challenges getting all the things that they need in order to fully ramp up. And I think this is something that we're going to be faced with throughout this response, because this response is going to go on for some time. And I just, in thinking about this, up until this point, virtually the laboratory sector worked on the basis of virtual inventory. So the supply chains were built for a certain volume of these components. But now those chains are almost strangled because, one, they aren't big enough really for all the demand, and they have to grow, and two, the producers, the manufacturers, the people that make the chemical reagents, solutions and everything, they need to ramp up getting the base supplies and their facilities to continue to and build up supplies and supply chains. So it's sort of been a perfect storm. It is much better now than it was back in March and April. But I think, as you have heard, this is something that we're going to have to we will be dealing with, the laboratory community, the entire laboratory community will be dealing with throughout the response.
This is Rachel Levine. So yes, I would agree. It's a problem everywhere. There are different platforms to be able to do the molecular tests. And I mean, our lab has about 5 or more different platforms to be able to switch from platform to platform depending upon which reagents are present. We did hear actually from the president of LabCorp that they do exactly the same thing. They have many different platforms depending upon where they're able to source the reagents, and it's something that he has to consider on a regular basis. Same with the hospitals. And of course, as was mentioned, this is a worldwide issue because it's a pandemic, it's a global pandemic, and so everybody needs to be able to do these tests. We'll see if the antigen tests are able to provide more assistance. Again, it depends on how sensitive and specific they are, and they'll also depend upon how many of those kits that we're able to access. So, for example, CMS is sending antigen kits to many nursing homes to be able to do rapid tests in the nursing homes, and we will work to support them on that. The question will be after the initial stores of kits are done, if we're able to if they are able to, with our help, source the kits. This will be the same. There's 2 different antigen tests that are currently licensed, the same nursing homes throughout the country. They're going to be receiving those from the Center for Medicare and Medicaid Services. So there'll be competition for the kits, which will make it challenging. So we'll see how that goes as well.
Great. Thanks, Rachel. Olivia, let's keep going with some questions then.
Sounds great. We'll go to our next caller. Please go ahead with your question.
Hi, this is Ken Alltucker with USA Today. There are some who are advocating for rapid at-home testing, antigen tests maybe, similar to like a pregnancy test. What do you folks see for that type of testing?
I'll start. This is Rachel Levine. So actually, you have good timing. The governor just had a press conference with the president of OraSure Technologies, Pennsylvania company, to produce just that, a rapid at-home test it'll be an antigen test, with hopefully very good sensitivity and specificity. And I think that would be a great advance. I mean, one of the keys will be, again, its sensitivity and specificity and its accuracy, so to speak, but also one of the keys will be how we get the results, so that we can monitor the positives and negatives and so we'll have to work that out. We'll see if that is available by the end, hopefully this year, in 2020, and I think that would be a great advance, both for a diagnostic point of view for individual patients, but also potentially if used from a public health perspective in terms of the different types of surveillance testing that we discussed. So I think it has great possibility.
Thank you.
Thank you. We'll move to our next question. Caller, please go ahead.
Hi, this is Donald McNeil from the New York Times. Can you explain in more detail the problems with the supply chain? I don't really understand. Is it that we don't have the needed nucleotides for the primers because they only come from overseas, or why is it we've had problems for months and months now? We have managed to ramp up ventilators and other things, but one keeps saying the supply chain has problems, but I never hear in great detail because it's talked about reagents and little plastic things, and I'm sort of wondering what is it that we can't produce in greater volume more quickly in this country that's causing all these roadblocks?
So this is Eric Blank. I'll start and let my colleagues chime in. So early on, it was the reagents. It was the test kits. There just weren't enough of them. What we're seeing now is, remember I said something about those 30 components needed for a test? A lot of those components are used throughout the laboratories. In other words, we work with environmental health laboratories. Guess what? They use plastics, the same kind of things that are used in COVID testing. They use the same kind of pipette tips. They use some of the same kinds of buffers and solutions and things like that for something that has nothing to do with COVID testing, but it's used in high numbers. We're seeing the effects of some of the supply shortages in plastics on our newborn screening programs that use a very similar kind of technology for newborn screening that is being used for COVID. So it's an issue, for now, it's a much broader issue from the standpoint that the shortages we're seeing are shortages for the supplies that are, if you will, agnostic to the test. In other words, they're just generally essential laboratory supplies that are used virtually for any kind of testing in any kind of laboratory. So it's not just that the 98 public health laboratories and the big commercial labs and the hospitals and academic labs that are doing COVID testing are competing for these things. They're also competing with many, many, many analytical laboratories, and as Dr. Levine pointed out, this is a global issue. So those are the shortages that we are seeing now, and there are the ongoing, because of the extreme demand for testing, we're still seeing some shortages with regards to the specific reagents for certain of the specific platforms. As Dr. Levine described, most of our members have multiple platforms, and clearly so do the commercial laboratories, in order to be able to provide some level of testing should there be a shortage of some particular supplies. And those manufacturers still, they're trying to catch up, but the demand has increased dramatically.
This is Rachel Levine. So, I'm in agreement with that. And there's a number of different components, right, to getting the test as was described. First you have to have the right swabs to be able to do the test, and then you need the viral media in a sterile tube to be able to put the swab in to send it to the laboratory. There are extraction platforms to extract the DNA, and then there's the testing platforms. And so we have seen shortages in every single component of that chain. The federal government is sending the states the tubes and the viral media. Occasionally there are problems with it in terms of transportation or what we get, but for the most part, the states are getting the tubes and the viral media from Health and Human Services, which then we can send out to hospital labs if necessary, or to our county municipal health department partners such as Philly and Allegheny that do some of their own testing, and then for our laboratory, et cetera. But then, we've had shortages with the chemicals for the extraction platforms, and then we've had shortages with the chemicals for the testing platforms, as had the hospitals. We have called Roche, we have called Hologic. They have described their challenges. A lot of it is because of the amount of testing being done in the United States and the amount of testing being done globally, and the companies that are producing those reagents are producing them as fast as possible, but it's a challenge.
Is there anything
Thanks,
particular?
Jennifer, anything to...
And sir, did you have a follow-up?
Anything particular that's missing, Eric or Rachel, you can point to?
Oh, I'm sorry. I thought the sound had been cut off. I'm still a little confused. Swabs don't sound that complicated. Little plastic thingies don't sound that complicated to make. Reagents, it's kind of, if these were tires or gun barrels or something like that, we'd have a clearer idea of where the holdup was or what the shortage was. But is it because they have to be imported from overseas, or is it because there's some limiting factor in the manufacture of reagents that can't be overcome because you need more complex machinery that takes months to build? Or why is it that these problems seem so insurmountable? Because we keep hearing there's a problem, but it's never discussed in such detail that you can understand, we need more of this kind of wire to make this kind of light bulb, or we need more of this kind of steel to make this kind of gun barrel, or something that's easy to understand. And I'm just wondering if there's any way to drill down harder into what's missing and what could be fixed.
I'm not sure I have wisdom to be able to give you an answer of what can be fixed, because I think it's a fairly complex issue. You can't make some of these solutions the way we might make a cake at home, even though we can be very careful with the ingredients and put them in the proportions in the cookbook. There's a little bit of room for error. For some of these things, there is no room for error. So indeed, in putting together an extraction kit for an extraction platform, everything has to be done very precisely. As Dr. Levine pointed out, most of these solutions have to be sterilized. So that's an additional step in the process that needs to be done. Some of the base chemicals are not in big supply, and yes, they are internationally provided. China is one of the major providers of some of the base chemicals needed. As to the swabs, for the kind of test that's been described, molecular test, you can't use a cotton tip because that's going to dissolve, and that contains genetic material itself that will interfere with the test. So these have to be specially produced swabs. And then when we had a swab shortage early on, there were two main manufacturers, one in northern Italy, which in spring, if you recall, was in the middle of its being in the pandemic, and a manufacturer in the United States. Gradually, they both started to increase their supply, and swabs have not been as big an issue as they were early on, but they could be if demand starts outstripping supply.
Can I just chime in to the larger point of Don, your question, which is that you're right. This whole issue has not been addressed at a national level. We haven't actually done the audit of exactly what the bottlenecks are in our testing capabilities, what is in short supply, how can we potentially overcome these shortages and these bottlenecks, and how do we best address the challenges that we're experiencing. I mean, you hear stories about individual states trying to sort this out on their own, sometimes negotiating with foreign governments for the importation of testing supplies, getting it here, finding out it's actually not going to work, and they didn't know that beforehand, and then they get supplies here, and then they have to negotiate with FDA in order to get approval to use it. And this is really not something that we should be doing on a 50-state by 50-state basis. This is something for which we should have a national approach, particularly if they are national issues. It's not even clear to me that the same problems exist in every state. It's not even clear whether the solution is just more technology or more supplies or whatever, but we absolutely need, and this is why people have been pushing on the federal government to develop a national testing strategy that not only defines what are we supposed to be doing with the tests that we have and should our approach to testing be, but what is the current capacity, and if it's insufficient, how do we fix it?
Thank you.
Thank you. Next caller, please go ahead with your question.
Hello, can you hear me?
We can.
Yes, thanks.
Hi, this is Jackie Lee from Bloomberg Law. Thank you for holding the call. I was hoping that you guys could address, Dr. Nuzzo, I think you mentioned this at the beginning, that as companies and businesses want to reopen, they're doing more screening and testing people that might not have symptoms, and because more testing will be going on, it might be harder to interpret those results. What are some things what's some advice you would give to a company or a business in handling that situation? What can businesses and companies do if they do get those results that are hard to interpret? What should they be doing, especially if we're trying to, help the economy recover or whatever, and people want to go back to work? What sort of strategy can there be to make that process faster and more efficient?
So this is Rachel. So, right now, as I mentioned and was mentioned also by Dr. Blank, we're really using a diagnostic testing system. To be frank, we don't recommend that a college test every student through the diagnostic testing system before they start school, or that a large business test everybody through the diagnostic system, because it generates thousands and thousands and thousands of tests, which then potentially make it more difficult when we're trying to test symptomatic people in the diagnostic system. There has been discussion by Dr. Giroir, the Assistant Secretary of Health, of trying to use some other type of surveillance system. It's still not really fleshed out yet in terms of how the states are going to do that, but as Dr. Blank was talking, I think that you do have to distinguish between diagnostic testing and surveillance testing, and use different platforms and different systems. For instance, you can do what's called pooled testing if you're doing surveillance testing. It's not great for diagnostic testing. You might be able to use some other types of platforms. So I think you have to separate that. So sending 3,000 specimens for a college class to LabCorp Quest for a college isn't the best use of that type of technology from our perspective.
Yeah, and this is Jennifer. I also referenced these comments, concerns about testing, particularly when we don't have any symptoms or any epidemiologic criteria for guiding. The interpretation of these test results is challenging. Now, I think there are some people who have a vision of using testing, that it's going to be ubiquitous and it will be the pathway to reopening our economy. And I don't entirely disagree, though I have deep concerns about those visions, in so much as they're being pushed without really thinking through the kind of operational consequences. One, of course, is on the demand for testing, and whether we have pushed for a level of testing that is, given current supply availability, unsustainable. But also, what do we do with these test results? Let's say you're somebody who gets tested, you have no symptoms, you've never been exposed to somebody, and your test comes back positive. Let's say you work in a nursing home. And, obviously in a nursing home, we would want to very much know that you are infected. And so what would likely happen is that you would be sent home to isolate for 10 days at least, for 10 days. And, during that time, you don't become sick. 10 days later, you report to work. But in that period of time, 10 days, you have not been on your shift. That has put in tremendous pressure on the nursing home. And then, additional nursing homes start seeing people, one-offs, that keep going through that. And eventually they start to get suspicious. So then they start sending out on their own, because the state that they operate in says a positive is a positive. They send out on their own for confirmatory testing on their specimens and find that they are negative tests. So this is a challenge that we have, where you're potentially making consequential decision on the individual levels based on test results that are going to be harder to interpret. Now, it's not to say that we shouldn't do that. Clearly, the example of a nursing home, we would want to know very quickly if somebody is bringing the virus in there, and there are benefits, but there are also consequences to inaccurately identifying somebody who, has to stay home then and is unable to work, possibly, putting patients at risk because of the shortages in the workforce there. So I really think that we need to think through how we're going to do this testing. And unfortunately, what's happened is that a number of businesses and organizations have basically kind of developed their own plans without really coordinating with health authorities to figure out how this is going to factor into the overall strategy within a state in order to do this testing.
Great points, Jennifer. Thank you so much. Why don't we keep going on questions if we have them, because I know we did want to promise as many opportunities as possible.
Yes, our next question. Caller, please go ahead.
Hi, this is Andrew Joseph at STAT. I apologize. I have kind of a vague question, but I'm trying to sort of project ahead a little bit, look forward a bit. And so I guess going forward, say maybe through the end of the year, is there a moment in September or October, November, where you expect something to happen on the testing front, or perhaps something needs to happen on the testing front? Is there a certain time when you foresee a milestone in testing to happen, or is there a certain time when you think that surveillance testing or pool testing or antigen testing needs to be really broadly available? And maybe that coincides with the fall and flu season or something like that. So again, that's a really vague question, but just wanted to see if it sort of sparked any ideas.
Any ideas? I think this issue of flu is also an interesting thing for the fall.
This is Eric Blank. I really think, as Dr. Levine has pointed out, and both Dr. Nuzzo and I have said, there are multiple ways of approaching the testing, but it has to be thoughtful. I think the messaging that's coming out that everybody ought to be tested and have access to tests has been problematic, because it then sort of short circuits how to best use these tests. And as we come up to the flu season, quite honestly, I think public health is going to have to, and I'm talking about public health broadly, but for our member laboratories, for the public health laboratories, they are going to have to continue to support their health agencies and what they're doing, but they're going to have to pick up on that piece of surveillance. And obviously it's influenza surveillance, but the bottom line is the symptomology is very similar between COVID and influenza. And so I think, I know our colleagues at CDC, and as I mentioned, CSD and APHL are kind of looking down the road saying, okay, what is our strategy going to be? What are the models? How should we integrate the influenza surveillance with COVID surveillance using essentially diagnostic tests? Now, we have the influenza model where public health does a certain percentage of folks that have influenza-like illness. Those specimens get sent to public health, but for the most part, influenza testing is done through healthcare providers in the private sector. I think eventually we will get there. I don't know whether it's going to be this season, but I think that's sort of the direction that public health should be thinking about as we go forward.
This is Rachel Levine, so I would certainly agree with that. In addition, though, I think that rapid antigen tests, if they are very sensitive and specific, if their accuracy is good enough, in the hands of healthcare professionals and even the home tests, but I think will be very important. For instance, most people get their, if you go see your doctor and you think you have influenza, they do a rapid flu test in the office. So, if you can do the rapid flu test and the rapid COVID test, then you'll know pretty much what the patient has if that type of rapid antigen test is available. So I think that very large quantities. So there'll be a number of different requirements. Large quantities of accurate antigen tests for COVID will be really important. The other thing it highlights, though, as we're talking about flu, is going to be the importance of flu vaccination. And so in Pennsylvania, we are going to be strongly emphasizing that. In fact, we've ordered about twice the number of flu vaccines than we usually do to try to have an extensive flu vaccine campaign, which I think will be critically important given the global pandemic of COVID-19.
Sorry, Dr. Levine, can you, why is that more important? Is it sort of a dry run for a COVID vaccine campaign, or is it because you really can't afford to give up ICU bed to someone with the flu? Why is that even more important than normal?
Well, I think it's really important because I think that we need to protect people from a flu season in addition to, because we're going to have two respiratory viruses that can cause severe illness at the same time. So the more we can protect people from the flu, the better. No one knows what happens if you get co-infected with COVID-19 and influenza, and I mean, that's never happened before, right? So since it's a novel coronavirus. So I think that, from state public health officials, and I know they've talked about this federally, the flu vaccine campaign will be really, even, if anything, more critical this year.
Thank you for those comments. I want to be mindful of the time, and I want to just remind folks that this call is going to be available post-production in terms of being able to share it. And if you do have follow-up in the meantime, please feel free to reach out to our ASTHO PR team, pr@astho.org. We're happy to answer questions and to connect you with experts across the country. But it is top of the hour, and I want to thank Dr. Levine, Dr. Blank, and Dr. Nuzzo for joining us. What a wealth of expertise and information. I feel another desk side briefing coming on around flu and COVID sometime soon. But in the meantime, please keep in touch as you're working on stories and you'd like to get a state health or territorial health agency angle. And thanks again to our Hopkins and our APHL partners. We're so glad to have you as part of our ASTHO team on this. And thanks to our ASTHO team for putting together really quality production on short notice. This really was an idea we had, I think, yesterday. So we appreciate everybody's participation. And if you have any follow-up or feedback for ASTHO, please do share it with us directly, pr@astho.org. With that, Olivia, I'll ask you to conclude our call. And again, thanks to all of our presenters for their expertise and time today.
Thank you, sir. And thank you all for your attention. This concludes today's conference call. All participants